We're really excited to be here today and wanted to start by acknowledging that probably there's a lot of knowledge in the room here that we don't have. And so as much as we're here to give a talk and want to share some information that we've learned so far, we hope that we'll also learn from you, especially people who are working on the front line or people who may have their own experiences to share. We hope to be interactive, so please get ready for some discussion as well. So we wanted to acknowledge that we approach this work from a really privileged standpoint. So we're both physicians, and I think by virtue of being physicians, there's certain things that we're able to see more easily than other people, and there's also certain things that we're just going to miss. And so, again, at any point, if there's things that you feel that we're missing in our presentation, put up your hand and speak out, please. We're not speaking on behalf of people who are experiencing homelessness or experiencing poverty, and we also acknowledge, obviously, that there are a lot of intersectional issues that impact how somebody ends up and why somebody ends up being homeless, including racism, including colonialism, many other things that we'll touch on. But we're here as allies, and certainly in the work that we do, we try to approach it from that standpoint. So the hope today is that we will cover these objectives, talking about the unique health concerns of people experiencing homelessness in Canada, but more specifically focused here in Toronto. Then talking about how to create a work environment that's welcoming to people who are homeless, and talking about an anti-oppressive framework that we can use to do that in a trauma-informed approach, because I'm sure as many people know, people who experience homelessness have often experienced trauma before becoming homeless, and certainly through being homeless experience further trauma, whether that is through their interactions with police, through their interactions in the shelter system, the medical system, etc. We recognize that housing status is in itself, alongside poverty, a fundamental issue for people who are homeless. And then we want to talk a bit how to address these issues, both on the sort of one-to-one clinical level or interaction level that you might have if you're working with clients, but then also on the broader systemic level as well. So this is just a bit of an outline how we'll cover these objectives, start a bit with your experience and questions, then we'll talk about some statistics and numbers, give a bit of context about what's happening here in Toronto, then delve more into homelessness and health, and then talk about interventions. So hopefully leave you with some really concrete ideas of things that you can bring back into your own work, wherever that may be. So we wanted to start with a bit of an interactive discussion. Really, what are your experiences working with people who are experiencing homelessness, and what are the challenges that you've faced? And maybe before we get started, is there anybody in this room here who doesn't work with people who are experiencing homelessness? Okay, so this is definitely a group where that is something you have already experienced. All right, so I'll hand it over to Samantha.
So I'm going to just start with some numbers, but we also want to acknowledge that, of course, it's not just about numbers. Homelessness is also about wealth inequality and capitalism, lack of access to power, and social and political exclusion, as well as systemic disenfranchisement. So this is about like macro issues that are, very that are broad, but we're going to get down into some of the details and the nitty-gritty. So here's some numbers. 15% of Canadians live in poverty. In Toronto, that number is 19%, and 1 in 4 Toronto children actually live in poverty. There are currently 156,000 Ontario households waiting for affordable housing. That, I'm sure that number everyone in this room is quite familiar with. In Ontario, probably everyone knows these numbers, but people who are on Ontario Works have a monthly income of $700. ODSP is $1,100, and the low-income cutoff for a single person is actually $2,000. So ODSP is just over half the low-income cutoff. So people who are on social assistance automatically are living in poverty. And this was a study done a few years back in Toronto that reported that ODSP recipients have about $4 a day to spend on food, and Ontario Works recipients have less than $1 a day to spend on food. So that's like a cup of coffee. Here's some numbers about homelessness. This is from a report from 2014. So on any given night in Canada, about 35,000 people are homeless. And over the course of a year, there are about 235,000 people who experience homelessness. So most people are not chronically homeless. About between 13,000 and 33,000 people are chronically homeless. And homeless is defined as either unsheltered, staying in emergency shelters, or provisionally accommodated. The majority of people who are not the majority of people who are homeless, but the largest demographic are men aged 25 to 55. But there are also homeless people with who don't fit that sort of stereotypic demographic. 20% of people who are homeless are youth. Families make up 4% of individuals, but actually 14% of total bed nights, so they end up spending a longer time in shelters. As we know, Indigenous people are overrepresented, and I've already mentioned that about 20% become chronically homeless. And here in Toronto, there's all sorts of things that affect our local context. There's gentrification in the inner city. I'm sure many people in the room have heard about the George Street revitalization and the upcoming demolishment of Seton House. There will be a replacement of some shelter beds, but not all shelter beds. There may be a net loss of shelter beds. And there's gentrification in other neighborhoods as well. As we all know, there's a lack of affordable housing in this city and a large wait list, and the shelters are overcrowded. So the city has set its own target of a maximum of 90% capacity on any given night, but they are never at that target. They are routinely above 95% capacity. And this was just taken, when we were putting these slides together, you can see that the occupancy rate was 94%. That was in April, so that's not midwinter. And the family shelters are at 100% capacity and are overflowing into motels. And this is an average nightly census for over the course of the last year in the city of Toronto. You can see that it's increasing. So for 2017, those numbers for January, February, and March are significantly higher than in previous years. And then there's the national context. I don't know if you wanted to speak to this slide, but I'm sure everyone remembers the person on the screen there and is thankful that he's no longer around. But I don't know how much more helpful Trudeau will be. We'll see. The National Housing Strategy is in development, will be released sometime this year. And we'll see what happens with that. But we are the only country in the G20 that doesn't have a national housing strategy, so hopefully that will at least lead somewhere.
and I guess just going back to this very pointed cartoon, who here has worked with people who have had contact with the criminal justice system? So most people. And how many of you feel that mental illness played a role in that contact? And that's certainly an experience that I've had working on the team where I work, where some people will repeatedly get taken to jail, and some people will occasionally get taken to hospital, or more consistently get taken to hospital. And we're actually going to look at some of those statistics on my team. My thought is that there's a possibility that race plays a role in who gets taken to jail versus who gets taken to hospital. But I think it'll be interesting to look at our team to see if that bears out in terms of the numbers. But certainly we know that in terms of people who are incarcerated, and a lot of the people who are incarcerated are pre-trial. So it's not that people have been convicted necessarily. A lot of there's a high rate of severe mental illness, as well as other mental illness as well. When we talk about severe mental illness, for example, schizophrenia, bipolar disorder, and then we know that when people are incarcerated, they're certainly exposed to further trauma, and that's something that, we talk about homelessness as if it's the people who are out on the street, and yet oftentimes I think we should also be looking at the population that's incarcerated, many of whom don't have anywhere else to go. And I've certainly had people tell me before, it's cold out, like I'm going to do something so that I have a roof over my head. And I mean, to me, that's just egregious that this is happening in our country that's as wealthy as it is. Has anybody else ever had somebody tell them something similar, that they, might do something in order to have a roof over their head in jail? Yeah.
Well, and there's also what happens frequently is people get discharged, as we all know, from jail to the street, or from hospitals to the street, but in particular from jail to the streets.
So now we wanted to shift gears a little bit and talk specifically about homelessness and health. And I think it's important to remember, this is always a bit of a humbling slide to those of us who are physicians or those of us who work within the sort of healthcare system as a whole, that what makes Canadians sick is not necessarily related to the healthcare that they're receiving, although that is certainly a part of it, but your life. So the social determinants of health, all of the things that you have going on, your income, your early childhood development, the amount of trauma that you're exposed to as a child, your disability, your education, gender, social safety net, all of these things actually make up 50% of what contributes to a person's wellness. Your healthcare access and wait times, et cetera, is about 25%, and biology is only 15%. And I think we often think of health as being sort of related to the healthcare system, and particularly for the healthcare providers in the room, it's good to break out of that and say, well, you know, I think any of us who do this type of work probably know that housing status, homelessness, et cetera, play a big role in how healthy people are able to be. And so what we're putting forward is that poverty is a medical problem. Income is the single most important factor which determines whether someone is healthy or not. Women, children, Indigenous peoples, people with disabilities, racialized people are disproportionately affected by poverty. And we didn't put them in this presentation, but certainly if you look at any, I don't know if it's any, but many different illnesses, you can see that there's a same sort of gradient, that if you are wealthier, you will have better outcomes in terms of cardiac disease, in terms of lung disease, in terms of mental health, in terms of suicide rates, etc. And so just to give some examples specific to homelessness, but I would challenge all of us to think, you know, this lecture is about homelessness, but if you look at poverty as a whole, you see sort of a consistent gradient. The more money you have, the healthier you are on average. But for people who are experiencing homelessness, 75% have one or more chronic disease. And this is from the Street Health Report from 2007, so certainly statistics may be slightly different now, but it gives you a sense of the burden of illness. Heart disease, 5 times as likely, cancer 4 times as likely, severe depression 30% as likely, diabetes 2 times, and certainly we know as well that suicide rates are higher for people who are experiencing homelessness as well as suicide attempts. There was a study that looked at the rates of suicide attempts and suicidality in people who were on ODSP and OW versus not. And again, you see that same gradient again. And so the reason we're sort of spending so much time on the income piece of this is that I think that's where some, I won't say easy, but certainly some doable solutions lie if we look at a broader policy level. As well, homelessness leads to increased mortality. This is from an article by Stephen Wong, which shows that life expectancy for somebody who's 25 years old, this is from an article in 2009, the average Canadian man would have a life expectancy of 77 years. Average Canadian man who lives in a shelter, so that's not even saying somebody who's street homeless, would be 64 years, so a loss of 13 years on average. And certainly in my work, I see that people pass away sometimes from things that are directly related to homelessness, but sometimes it's from lack of care for medical issues, that they had difficulty getting that access because of homelessness. So we wanted to have a little bit of a discussion here. How does homelessness cause illness? And again, your experiences. And maybe we can just take 3 minutes. You can turn to the person sitting next to you, and then we'll come back in a group. So if you could just answer, how do you think that homelessness causes illness? What we had thought, again, this is not an exhaustive list, but certainly being in a crowded shelter, you have more chance of getting communicable diseases. So, I mean, we know that at Seton House there's been an ongoing outbreak of group A strep. If there's tuberculosis in a location, or if there's scabies or lice, I mean, I have prescribed more Nicks in this work than in anywhere else, so like a treatment for scabies or for body lice, and that can certainly, I mean, be stressful being crowded, but also lead specifically, can people hear me? Yeah. To increased communicable diseases. As well, long periods of walking and standing, and you can get stasis in your feet. And so for anybody who's working with people experiencing homelessness, always ask how their feet are doing. In the wintertime, obviously, make sure that people have dry socks because you can get all sorts of infections. And but if sometimes when people don't have places to sleep, they might sleep on a park bench, so sleep sitting up. And you can get people with a pretty significant leg swelling, which can then lead to skin cracking as well, because the flow of blood doesn't come back up sufficiently, and so you get all sorts of complications from that. Certainly fungus as well. And then when somebody has diabetes, if they are not able to feel their toes as well. So after a long time of having diabetes, they might lose some sensation in their toes, and then they could stub their toe, and that could actually turn into a pretty significant complication. So always ask people how their feet are doing, and if you're able to and is appropriate, even take a look at their feet, because they might not know how unwell their feet are. Prolonged exposure to the elements, risk of frostbite, risk of heat exposure, uncertainty, stresses has been mentioned. Lack of personal and safe space, and this is something that I've been thinking about a lot in my work, because I work with a range of ages, for anywhere from sort of young adult, sort of early 20s up until seniors. And if you're homeless and if you're living in a shelter, you're not allowed to have a private sphere in a way. So if I have a rough day, I can jump up and down in my apartment, I can scream, I can throw a pillow, and nobody's going to call the police. Nobody's going to think that there's something wrong with my mental health. Maybe if somebody's around, they might be like, well, you should have a lie down in your room by yourself. But I'm allowed to act in erratic ways without it being seen as a mental illness or without it being seen as a criminal issue. Similarly, I have a patient currently who is a young guy. He's living in subsidized housing, which is fantastic. And he wants to have a girlfriend stay over because he wants to have sex, because that's a normal thing that people do. And that's part of being healthy, in fact. But because of the rules at the housing, he's not able to do that, and so is potentially going to lose this housing. And I've had many patients as well who have been living in a shelter and they're masturbating, and then they get, somebody walks in on them, or it's obviously inappropriate because it's in a public place or it's in front of other people, but there's nowhere else for them to do that. And again, like for anybody who's housed, we're able to live all these different spheres of our life without it being pathologized. And so I think that's just something that it's been more recent that I've been thinking about, this lack of privacy and this lack of personal space. Food deserts, right? If you are far away from somewhere where you are able to obtain fresh food, you're going to go to the corner store, you're going to get a bag of chips, you're going to go to a drop-in that might have free pizza or something that is, going to tide you over and give you calories, but not going to lead to a healthy life.
Well, and again, there's pathologizing that as well. So in the shelter system, if someone, doesn't like a particular meal, like in order for them to actually access, any other kind of food, they need a doctor's note to say that they have food restrictions, or they need a doctor's note to say they need a certain number of calories in their diet. They're not able to request like additional food unless they have a doctor's note.
And then, of course, lack of access to transportation or to a phone. So if you want to make a follow-up appointment with your patient and they don't have a phone, or with your client, what do you do? I mean, who here has had that trouble with working with somebody, doesn't have a phone, doesn't have email? I mean, I think we work with a very unique population that doesn't have access to sort of communication in the way that pretty much everybody else in Canada does. And that sort of takes a reframing for people in the health system. So we wanted to take this the next step further and talk about specifically the challenges in getting appropriate care. And so, I mean, that could be health care, that could be social services care, and what sort of experiences you've had in, again, that specifically that access to, whether in the Emerge, the inpatient unit, social service agency, even legal help. And I mean, I think that touches exactly on the issues that we're talking about here, the stigma, both, what happens in that moment, but also sort of the reputation of somebody's like, oh, so-and-so is here. And we're often quite inflexible in the healthcare system and saying, well, so-and-so, that happened then, but they're different now, and let's give it another chance. Lack of support for getting to appointments, we talked about that already. Nowhere safe to store medications, or in your case, somebody needing support to take those, right? I mean, in the shelters, things vanish all the time. and then somebody will come to their doctor and say, oh, you know, I lost my meds, and the doctor may or may not be able to re-prescribe those. Incarceration is often an issue, right? If somebody is incarcerated for a period of time, but they had their specialist appointment that they've been waiting for 6 months, but nobody told the specialist, again, that can lead to challenges in communication. And also, people often present to care with acute issues, and so you're dealing with these emergent issues all the time. Maybe that's something that Samantha as a family physician can speak to more, but the prevention of, you know, ongoing and chronic health issues is often overlooked because we're sort of setting out fires of, you know, this person's leg is broken. Like, well, they also have diabetes, and that's causing a long-term concern. Yeah.
Okay, so I'm going to start off on some tools that we have to intervene in homelessness. I mean, I think there's more expertise in the room than what I have, but hopefully we can do this together. This is just a diagram to show that there are multiple levels where we need to intervene. So we'll intervene at the micro level with our individual clients, at the meso level, so on the community level, and with our agencies or clinics where we work, and then, of course, at the macro and policy level. And it's important, and Michaela will talk about this later, but for us to consider engaging in advocacy for change at that level. So starting with individual. First of all, of course, it's important to screen everyone for both poverty and housing instability, because it's not always obvious, and someone may be housed, but it may not be safe, it may not be stable, they may be at risk of homelessness. And this is a screening question that can be used to screen for poverty, and it's been validated. So you can ask, do you ever have difficulty making ends meet at the end of the month? And then intervening. So these are some things that we can do. So I'm going to go through 5 key elements. This was developed more for use in a clinic. So 5 things that can be done in a clinic to improve the care provided to people experiencing homelessness, but I think it's relevant for agencies as well. So the first might be obvious, but is to use an anti-oppressive framework. So being aware of one's own power, privilege, systemic biases, because each of us, even those of us who do work a lot with people experiencing homelessness, have biases that are ingrained, have power that we're not always aware of, and of course privilege as well. And it's important not just for us providers, but for everyone at our agency, so clerical staff, anyone who's going to be interacting with the clients who we serve, because often actually it's the clerical staff who are the very first person who someone's in touch with, and it can be a clerical staff who pushes someone away. And as we've already talked about a lot, of course, there's evidence, I mean, there's research that shows that homeless people do often report suffering discrimination in a healthcare setting. So the second, and I've already sort of touched on this, is to develop an organization-wide approach and expertise. So training everyone, staff, learners, students, to be welcoming, non-discriminatory, respectful, and informed of trauma, and that's the third step, so I'll get to that. Accommodating walk-ins wherever possible. So yeah, of course, like we all like, at least in my context of being a family doctor, I prefer to have my appointments booked, but it's important that I also allow people to come in when they can, because people can't predict their schedules when they need to get to a free meal across the city for lunch on a Monday, and they may only be able to see me at a given time. So accommodating walk-ins is important, and accommodating people for longer appointments as needed as well. So a trauma-informed approach could take like several hours to go through, and some of you may already know about this framework that's been developed, but these are the 4 elements. So the first is to always be aware of trauma. Most people, I don't know if we have data on what percentage, but most people who are homeless or experiencing homelessness have experienced trauma. And so just keeping that in the back of our minds whenever we're interacting with someone who's homeless. And then engaging in a safe practice, so being that means physically safe. So speaking of the security guards, we have a security officer in our clinic, and trying to make sure that the environment feels safe. So the security officer isn't like out front and center, and it feels like a safe place for someone to be. Being culturally safe, so culturally appropriate with people, and emotionally safe as well. So maybe not always discussing trauma, only discussing trauma when someone is ready, and just allowing a safe emotional space. The third thing, which maybe is, going from obvious to least obvious. So empowerment, so supporting client choice and shared decision-making whenever possible. And then finally, resilience, so actually highlighting strengths and instilling hope. The third point that I have here is, sort of similar. So attending to the client's priorities, talking about specific goals that someone might have, allowing the client to dictate the pace and extent of your engagement together, and developing a longitudinal relationship over time. Fourth is important, particularly in the kind of situation where I work. So ensuring appropriate follow-up plans are made, and ensuring that we have multiple pieces of contact information, because even if someone has a phone today, they might not have a phone tomorrow. So getting an email address, alternative contact information, a friend's phone number, etc. And also seeing people on the street. So, doing a home visit to a shelter can be helpful. Going and finding people. And this is the last point. So actually addressing people's social determinants of health by helping them maximize their income. So applying for extra benefits, applying for ODSP if they're not already on ODSP, and connecting to housing and income resources such as the folks in the room, and helping people make an access point referral, using whatever social resources we're aware of in the community. And these are a few specific things that we can ask to maximize our clients' income. So making sure that everyone has filled out their taxes, because anyone who's living on less than, let's say, about $30,000 a year, if they file their taxes, they're going to increase their income. So making sure that they've filed their taxes, and they'll end up with like HST tax rebates, various other tax benefits. Making sure that seniors have also specifically applied for filed their taxes, because that is what leads to them getting old age security and guaranteed income supplement. And if families file their taxes, then they'll get the universal child care benefit, which is huge. That can actually double someone's income. Making sure that anyone who identifies as First Nations or Aboriginal, asking whether they're registered Indian, because then they can access extra benefits. And making sure that people have applied for extra supplements, including transportation benefits, special diet forms. And then finally, if someone seems that they might qualify for ODSP, trying to connect them with that application. And these are a few resources that might be of use if you don't already know about them. The first is, they're all websites. So the first is a website, Canada Benefits. It's an online portal to figure out what benefit someone might qualify for. You can plug in your information, your age, the province where you live, and then it lists everything that someone perhaps might qualify for that they could apply for. The second resource is 211. Who in the room has used 211? Okay, yeah, that's many more than people in the healthcare environment. So 211 is a phone number that you can dial. It's also a website to figure out what services exist in your postal code, your region, such as food banks, shelters, OHIP-covered physiotherapy, etc. And then the final website is Your Legal Rights. So that's a really easy to use, easy to read website that lists like first of all, it lists all the legal aid clinics and by neighborhood, and then it also lists various legal rights such as housing, disability rights, income, etc. And then this is a guide that was developed by the City of Toronto that you probably all are aware of, but it's on the City of Toronto website, and it's a guide to services for people who are homeless in the city. So it's a comprehensive list of things like food banks, shelters. I'll skip that. Do you want to?
So before getting to the systemic solutions, we wanted to talk a little bit more about ODSP. Who here has helped somebody get onto ODSP? Okay, so a fair amount of people. I do a lot of ODSP assessments, and in preparing for these presentations, I've certainly learned more about how people can increase their income. So the first thing, obviously, if somebody isn't already on OW and they are experiencing homelessness and they're unable to work, it's best to get some income support in the meantime, even before you get to the stage of ODSP. Then in order to get onto ODSP, the person would need to get the application and take the form to a physician, and they have to meet the definition of disability, which could be mental health or physical health or addiction. And so it wasn't always addiction, but I think that's really important to remember. If somebody has a severe substance use disorder, that can be the basis for their ODSP claim as well. And then you have to submit it to the DAU, the Disability Adjudication Unit, within 90 days. But if somebody isn't able to work within those timelines, you can actually get on the phone and call and get an extension as well, which can be really helpful because otherwise the time will just expire. And it's really helpful to include test results, reports, etc. And while you may not be able to be the person doing that, if you're working in a community agency, you might want to go with the client to the physician and ensure that the physician is doing a good job, because we know that a lot of the forms are declined actually the first time around, and then people have to go to an appeal process. So if anybody who's declined, I would suggest considering an appeal. Sometimes it's because the condition isn't appropriate, but a whole bunch of them actually get approved on the appeal. I forget the percentage.
So 50% get approved on the initial application, 50% get denied, and then an additional 15% get approved after appeal.
So it's definitely worth going to an appeal, because sometimes the physician might not have filled it out totally appropriately, or there might be other reasons why that's the case, and even getting legal aid, speaking to legal support around the process can be very helpful as well. So you'd have to ask for an internal review within 30 days, and if that's declined, then you go to the Social Benefits Tribunal, which is the next step up. And then just a very short update on medical reviews. In the past, so there's always been a time frame for when ODSP would be up for review, but those reviews were never done. And then a couple of years ago, the government, following an Auditor General's report, said, we need to start doing all of these reviews. And so people started getting in the mail these packages. Anybody see those packages, or their clients see the packages? Yeah, so there wasn't a ton of them yet, because thankfully through some advocacy, the government heard that this is actually not the appropriate way to go about it, and so now there's been a whole redesign of the forms to make them easier. So hopefully people don't have as hard of a time to go through the medical review. So depending on the condition, the review might never happen, or it might happen within a couple of years. I personally think, a review in some conditions makes sense, right? If somebody has leg injury, that doesn't mean they're going to have a leg injury forever. Whereas for other conditions like schizophrenia, it's unlikely that that condition is going to resolve enough where somebody's able to work. Now, just a quick note on supplementary benefits. Many clients are eligible for supplementary benefits if they're on OW or ODSP. So obviously the Ontario Drug Benefit Card, and so people should have access to medications. If you're working, or if you want to work, so some people really don't want to work a bit, you can earn $200 a month, and after that 50% is deducted, and you'll actually get an extra $100 from ODSP for working. And so it is actually worthwhile for people where work is an important part of their recovery, or something that they're able to do, to say you can do that and you'll come out a little bit ahead. There's a pregnancy and breastfeeding allowance, $40 to $50, so $50 if you are lactose intolerant. So for anybody who is pregnant or breastfeeding, you can get them that extra $40 to $50 a month. Special diet allowance is for certain medical conditions, and that is maximum $250 extra a month. But again, these can add up, and Housing Stabilization Fund, so you can get some first and last month's rent, furniture, moving costs. There is a maximum for that, but certainly something to consider as well. And the port of entry would be through the OW worker, ODSP worker. And then the employment or training startup, you can get up to $500 to begin or change jobs. And that can be, you know, if you want to get training, something for volunteering. Like I have a client who got boots, for example, because she wanted to work in construction. Rooming costs, license fees, glasses, tools, etc. So that's a pretty significant amount of money. It's not, I don't know if it can ever recur, or what the time period on that is actually. Maybe somebody in the room knows. Yes? Every year? Okay, so $500 every year. That's more than I thought it was. Yeah. So sometimes it takes advocacy from sort of the team that's working with the client if it's felt that, you know, they're being turned down without appropriate cause. And then the mandatory special necessities form. This is something that transportation cost for transit. So if you get, I'm not quite sure of the exact number, but if it's 22 or 24 trips a month, then you get enough money for a TTC pass. Does anybody know the exact number?
Yeah, it's more than 3.
So you can apply for this if it's more than $15 a month. But if it's around...
My understanding is 25.
So it's, yes, if you have appointments 3 or more times a week, and then it's $146.25.
All right. Thank you. And the thing to remember, though, is that if somebody has to go to the pharmacy daily because they're on methadone, for example, that can count. And as a physician, I did not know this. So it's worth having a worker go to the doctor and say, actually, this counts. If you're going to an AA or NA group and it's actually part of the physician's care plan, this is like really, really unfortunate that it's so much the physician has to be the gatekeeper or the nurse practitioner as well. But as long as that's part of their treatment plan, that can go on there as well. Massage, labs, so if somebody is on a medication or has a health condition where they need regular labs, that can also be part of it. And then obviously supplies for special medical needs, if somebody needs diapers, surgical supplies, diabetes supplies, etc. And then vision care, you can get new lenses and frames every 3 years or any time for kids. So again, that's something to really think about that. Yes?
It's 2 years for the vision care.
Oh, thank you. Okay.
Absolutely. And sometimes for children, also, if the glasses break, it will be less than for sure.
Yeah, okay.
I want to add also with the drug card. So now the health card loads up.
Right.
Yeah,
Which is helpful for our homeless folks because at least they only have to manage, well, they lose their health cards, but the prescriptions, they can use your health card.
Yes, thank you.
And for those in the room, I'm sure you already know this, but those who are on Ontario Works rather than ODSP, they just need a letter for transportation funding. So a letter from a doctor or a nurse practitioner rather than a form.
And I guess maybe we can turn it over to the audience very briefly here. Are there other things that you think we should have included in this section about ways that people can maximize their OW or ODSP entitlements that we didn't include on these slides?
I didn't catch it was there, the employment training startup fund.
Yeah.
That was there, but just if you go back, I just remember there's a list of things included. But it also you can use it for record suspension. So if you're trying to get rid of a criminal record, it's $628 or something, but $500 is a big chunk of that. So
So it's separate. So the full-time, there's a full-time employment benefit. So if they show that they're eligible for the 500, the record suspension is separate. So if they go and apply through like John Howard, and then we get the fax and it's covered, it doesn't come out of that 500.
okay.
Yeah, so
That's even better. Thank you.
Yeah, there's more money now.
That's awesome. Thank you. Anything else that we missed? Yes.
Something that just comes up once in a while, and I don't know about the people who are homeless, but that there's the ability to expand the drug coverage. So a physician can request, so if a specific medication is not covered on the drug plan, the physician can make a request to the provincial government to expand that coverage to cover.
So that's like drug specific. It's called the Exceptional Access Program. And depending on the medication, sometimes the approval is almost instantaneous.
So generic versus name brand, for example, often comes up because there's side effects from the generic that's not functioning the way
Yeah, or pharmacotherapy for addiction is another one.
Okay, well, thank you for I always learn something when we do this because other people know more. So we just wanted to end off, we're getting close to the end of our presentation, with a bit of a discussion about larger scale interventions, because certainly for myself, working one-to-one with clients, I find it incredibly rewarding. It's beautiful, frustrating work. And sometimes it feels like there's only so much I can do one-to-one with people, and that's where I start looking at broader system solutions. And so both Samantha and myself are part of a group called Health Providers Against Poverty. Certainly, if anyone's interested, we're happy to tell you more about the group afterwards. But it's a group of health providers. We have a website, and there's resources and different things there where we do advocacy more on the systems level. And I'm interested to hear, especially if around HIV and homelessness or other areas that people have had experiences about advocacy or have had thoughts about where advocacy needs to happen, again, on the larger systems level. So,
and as a plug, our AGM is next Wednesday.
Yeah, so any thoughts? Yes, thank you.
I just want to know, because I'm a social worker public health. We also do micro levels. So what we do is if we see issues, individual issues become a common issue, maybe 3, 4, 5 cases, similar issues, right? So we go through the legal procedure, right? That is when MPs, continue advocacy to have impact on policy change. So I give example, I'm thinking maybe people have a similar experience can also happen too. So when we're talking about the OW, we have if people lost the weight and some kind of illness, they give you called a special bag program, right? So I give example as I work for TB program. TB patient lost the weight is very typical symptoms. Now on that form says if you lost the weight, less than 10%, you get 181. If you more than 10%, you get 200 something, right? So now they have a list. If you lost the weight, you also have to indicate. Doctors, nurse practitioners need to indicate what kind of illnesses, right? So TB is not on the list. Mm-hmm. But the weight loss is a typical one. So we try to fight, we have lawyers, we even go to human rights court, but we haven't done anything. The government tried to put a more illness on the list, but the TB is still not included. So I'm thinking, if anybody did a similar thing, fight for this kind of benefits in the cases, public health benefits, like we help you guys too, right? And also I want to know, like, any other interventions you are doing now for the policy change and benefits.
I mean, I think that's an excellent example of how there are gaps still, and especially if it's a population that you work with, I think it's fantastic that you're speaking out and sort of writing letters and doing those things. I think it's often a long fight, and working together and collaboratively with other people and other organizations, getting Toronto Public Health on board, thinking, again, everything from community organizations to city organizations, to provincial organizations, to federal organizations, health provider organizations. So sometimes, you might get infectious diseases specialists on board, or you might get the Pediatric Society for other issues. So there's, I think, many different ways that we can approach advocacy. I don't have an exact answer for you in the situation, but certainly I think identifying those gaps and then talking about them in whatever avenue you have is very important. And I mean, as physicians, I mean, we sort of work inside an office, even though most of my work isn't really in an office, and Samantha works in the shelters, etc. But I think thinking outside of the office and what we can do, I mean, sometimes this means, fighting on the streets, working with community organizations such as OCAP or other organizations that are specific to a certain diagnoses or demographic. Fighting for an increase in rates, I think, is very important. I mean, we know that the ODSP rates and OW rates are insufficient in Toronto. I mean, you can't get an apartment for, the rates that people get, right? And that's why people end up in the housing or lack of housing that we've been talking about. And then advocating for food, social services, healthcare. I mean, these are ongoing struggles that I think those of us who work frontline, I know for me at least, that's what keeps me going, because I couldn't do it without that broader systemic advocacy. So for example, around the, like with Health Providers Against Poverty, we sometimes take to the streets and do a demonstration around a certain issue, or join other groups that are fighting for housing or fighting for increase of rates. Sometimes we engage in research or helping other organizations do that. So it really, I think, depends on what your skills and your passions are and where you can take those. But I'm curious, maybe one or two other comments from the audience of sort of systemic solutions that you could see out there. So, I mean, thank you everyone for your fantastic participation and for all of the really amazing hard work that you do. And thanks for coming out today.